welcome to this week's installment of Med School. My name is Daniel Tweeday. A little bit about me. I was actually born down the street at St. Mary's. Grew up across the bay in Oakland. Did my undergrad at Georgetown University, where I got a bachelor's in biology and a minor in English Lit. Remember that when you see a bunch of my typos in here, and try and disregard that. And then I did med school right here. Spent a lot of time where you guys are. And I also did residency here in orthopedic surgery. I did a one-year fellowship in foot and ankle surgery at Harborview in Seattle at the University of Washington. And then I've been back on faculty here since 2014. So minus that one stint in Seattle, I've been a part of UCSF since 2002. So I've been here a long time. And it's my pleasure really to talk to you today about a really interesting topic in foot and ankle surgery in my world, talking about ankle replacements and ankle fusions and about surgery and recovery. I have no disclosures on this talk. And interestingly, so in this world, there's still a little bit of controversy. And we'll go through a little bit of the history of these and what they all mean, and towards the end. But there's still a little bit of controversy about which one is better, how people do. And so I'm going to start off this talk by giving you a video. And this video is actually a recruitment video. It was put out by the NHS, the National Health Service in England. And the reason for this video is they were doing a randomized trial of patients, trying to get them to do either a ankle replacement or an ankle fusion, really trying to kind of hash out which one is better, which one from which do patients do better. And so this video, I think, is a good kind of introduction to things that will get you thinking about where we're going.
My name is Sebastian Gordon. I suffer from arthritis in my ankles. I call my arthritis in my ankles comedy of organs, really, because my acting career was very physical. I was tumbling, falling, I fell downstairs just for a laugh, and I'd fall out of windows again for a laugh. And realising that years later I would suffer for it because I was really punishing my joints. And the pain came around when I got to about 50, and then it became almost impossible to carry on doing any physical work. So I had to get it fixed.
As you can see, ankle arthritis is a disabling condition. Most cases occur after trauma, such as multiple severe sprains or fractures of the ankle. This leads to progressive wear and tear of the shock-absorbing cartilage, and over years, the development of osteoarthritis. Ankle arthritis can also be caused by other diseases, such as rheumatism or gout, but the end result is the same. The cartilage becomes worn away, bones can rub together causing pain, stiffness. It can have a major impact on the quality of your life.
I had to stop working social in a company.
I was hardly able to walk at all. It just gets me across the bedroom to go to the lounge room.
I couldn't even stand very long for washing up or cooking.
Usually downstairs, I've been able to drive a car.
Every year, up to 29,000 patients are referred by their GP to foot and ankle orthopedic specialists to discuss surgery for their ankle arthritis, but only 3,000 of those ever come to surgery. Before surgery is considered, there are many non-surgical treatments that should be tried, such as using painkillers, changing your activity levels, weight loss, and physiotherapy. Supported ankle braces can also be very helpful. If all these treatments have been tried and you remain in pain, then surgery may be considered. The two main surgical treatments available through the NHS are ankle arthrodesis and ankle replacement. Ankle arthrodesis involves removing the arthritic joint surfaces. The two bones are then held together with metal screws or plates to stop any movement, and over time, the two bones fuse together to become one. This can be a keyhole procedure or open surgery, depending on your circumstances. In total ankle replacement, the arthritic joint surfaces are removed and resurfaced with metal components. A plastic insert is then placed between the metal surfaces to allow motion. After both types of surgery, you are likely to need a plaster or a boot for up to 3 months, and may be advised not to wear for the first few weeks. This will mean crutches or a frame to get about. Every patient is different, and your surgeon will discuss the most appropriate post-operative plan for you. Both ankle arthrodesis and ankle replacement can offer excellent results and improve your quality of life.
I can certainly cycle happily, swim happily. I was doing 20-mile walks quite happily.
I can do my own shopping, which it was getting that because of the weight carrying shopping, I couldn't do it. There's very little that I can't do now.
I can do 20-mile walks a week, and I'm absolutely no problem.
I'm walking very well, and without any total flexibility. Now's the time to see whether I will be tired of I can take this up as another hobby on top of the gardening and everything else.
Of the patients you just see have had ankle arthrodesis, and the others are replacements. I certainly can't tell the difference. Can you?
And that's the reason I wanted to stop it. The thing I like about this video, and I often have shown this video to my own patients, is just that statement right there. You see these 4 people, they all have good results. 2 of these people have had a fusion, 2 of these people have had a replacement, and yeah, I can't tell. Even looking at them, I can't tell who it is. And that's where the ongoing controversy goes into. We'll get into a little more about who's appropriate for one, and from my world, that's what makes it a little bit exciting, is trying to figure out. This video, obviously, is not that old. It's from 2015, and it's British, so you know it's very smart. And it just sums up everything really well, and in a much nicer accent than you'll hear from me. So, in this talk, we're going to talk a little bit more, expand a little bit about what we said there about the anatomy and pathophysiology that's involved in the ankle and ankle arthritis. We're going to talk about the etiologies, about pain generation, because that's really what surgery is all about, is eliminating that pain, restoring function. We're going to talk briefly about non-operative treatment, and then we're going to dive in a little bit more into the surgical treatments, fusions, and replacements. And we're going to talk a little bit about, trying to figure out choosing the right treatment. So what arthritis is a loss of cartilage. And when you get this loss of cartilage, it leads to inflammation, and the inflammation leads to pain. And pain is usually with loading or movement of the joint. And this can be caused by a number of different reasons. And when we think about it, we usually will think of this more as an osteoarthritis or a rheumatoid or an inflammatory type of arthritis, but the end result really is the same, where you lose the cartilage, and as a result of that, the nice smooth surface that normally works for these joints in order for them to move is gone, and your body, it kicks up inflammation, your body signals that as pain. And osteoarthritis is really the most common joint disease around. It affects 50 million Americans a year. I'm sure some people in this room suffer from this. I know I do. And about 12% of osteoarthritis is the result of prior trauma. But when we talk about osteoarthritis, it's important to know that different joints really are different. The mechanics are different, the arthritis patterns can be different. And the treatment, some treatments that work really well for one joint may not work as well for another joint. And so if you look at acetabular fractures, about 25% of these will result in post-traumatic arthritis. And only about 6% of total hip arthritis is related to trauma. So the vast majority is related to just idiopathic wear and tear, maybe some slight abnormalities of the anatomy. Of the knee, 23 to 34% of tibial plateau fractures will lead to post-traumatic arthritis. But again, only about a quarter of knee arthritis is related to prior trauma. This is contrasted to the ankle, where if you have a bad, what we call a pilon fracture or a plafond fracture, over 50% of those fractures will go on to getting arthritis, and almost 80% or more of ankle arthritis is related to prior trauma. So the vast majority of ankle arthritis is related to prior trauma, and this can really play into the disease itself. So this is the ankle joint, and for anyone who's done any woodwork, they'll notice this is what we call the mortise joint. And so it has these bony blocks around the outside, from the lateral malleolus, where the fibula is on the outside, and then the medial malleolus and the posterior malleolus, which the tibia is, and it creates this kind of U, and the talus underneath sits in that U. And this is a very stable, like in woodworking, this is a very stable joint. And as a result of that stability, the ankle tends to be very resistant to arthritis under normal circumstances. Actually, despite the fact that the ankle is so much further down and taking more weight than your knee, the ankle cartilage is about half the thickness of the knee. And it's because of this construct right here. In addition to the bones that are helping hold this ankle together, you also have some very strong ligaments. And these ligaments you can see here, especially along that outside where the tibia meets the fibula, and these are the ligaments that are oftentimes sprained. And here you can see in the back, there's some ligaments in the back. The back has less of a need for ligaments because the bone in the back of the tibia actually curves down in what we call the posterior malleolus. So the front, or let's say the back of the tibia and the back of the ankle is more stable than the front, and that's why people will tend to sprain kind of out the front. And what we know is that in that stable condition, things are good. But in an unstable condition, such as when you have a fracture, or if anything causes that tibio-talar joint space to move or shift, even 1 millimeter, this 1 millimeter shift in the talus causes a 40% change in the loading pressures on the joint. And what happens when the loading pressures on the joint change is the cartilage doesn't like that, and it will start to degenerate. And so this is actually one of the more crucial orthopedic papers, at least in the foot and ankle literature, to explain a lot of what we do, especially around ankle fractures. So here you can see in these top two images, this is an ankle fracture, and what you can see is that talus underneath has now shifted out from that nice stable mortise. There's this what we call a bimalleolar fracture. The malleoli, named after mallets, I'm sure you've all seen them on your own ankles, those bony protrusions you have. The one on the outside called lateral, and the one on the inside is the medial. And when these are disrupted through a fracture and the talus shifts, this is a very unstable pattern, and that will almost assuredly, if we do nothing, lead to arthritis. And this is really one of the driving forces of why ankle fractures require surgery a large percentage of the time. It's to try and recreate the anatomy to make this a stable joint again. And by making it a stable joint again, you hopefully minimize the risk of arthritis down the line. One of the things that goes along with ankle fractures is that ligaments often can get torn as well, and so you can have some instability from the ligaments. Or if you have multiple sprains, that can happen where you get this instability, it can lead to arthritis as well. And the other thing that happens, even with a very stable joint, when you have arthritis like this, you can see as that talus swept out to the side, sometimes those areas of cartilage have hit each other. And just that compaction can cause a cascade to lead to arthritis later on. And so the ankle joint itself is very resistant to arthritis under normal circumstances. But once it's disrupted, it is very susceptible to arthritis. And so this is a patient of mine later. I did not treat her initial fracture, but here's her initial fracture. This is it being fixed. Ankle joint overall looks pretty good. Here it is about 3 months later. You can notice the broken screw, which means there's probably a little more movement than we may like. Here it is a little further down. They actually removed the screw because it was causing pain. Another 3 months later, doing okay. Another 3 months. So that's 6 months later. Okay, removed all the hard work. She's still having pain. Another 6 months later, cleaned it out. So she's now undergone 3 surgeries. Keeps going. And eventually now you can see that her joint has collapsed. Any guesses as to how long this took? 5 years, right? This is a 19-year-old when this injury happened. 5 years later, she already has end-stage ankle arthritis, to where she's basically bone on bone and rubbing. You can imagine that this is a very painful situation. It's very debilitating. She has a young son, a very, very sweet woman. And this can be a short amount of time, and that's why it can be a long amount of time, it can be a short amount of time, and it can be hard to predict, but we do know that fixing a fracture and fixing it well can help prevent this and help at least prolong it so as long as possible. So post-traumatic is by far the most common reason to get arthritis of the ankle, but it's not the only reason. And like we talked about, ankle instability plays a role too. So if you have multiple bad sprains over a lifetime, if you have more than 5 bad sprains in a span of 3 years, there's one Japanese study showing that that really increases your risk of arthritis. And we do see plenty of people who will come and relate that, yeah, they remember having a number of bad sprains. They played college volleyball or soccer, they had a number of sprains throughout their lifetime. And then presenting in their 50s or 60s, that's when the arthritis kicks in. It can be that long and that late of a period of development. And then rheumatoid arthritis arthritis certainly can cause it, and also deformity. So if you have like a general deformity, if you have a growth deformity due to illness or something else like an infection, sometimes this can lead to it as well. And so what happens with ankle arthritis? Well, the biggest symptom really is pain, and the most noticeable one, right? Pain is your body's way of telling you that something is wrong. And when it's inflamed, it will stimulate those nerves around the joint to signal to your brain. It also gets stiff. The movement will be decreased. You'll get swelling as a result of the inflammation and everything else, and it can also deform. It can start to go into varus or valgus, meaning turning in or turning out. It can start to contract. You can develop bone spurs. Bone spurs happen in pretty much every joint in the body when there's inflammation, and it's almost like your body's saying, hey, don't move that joint. And when you don't want to move the joint, how do you not move something? Well, you form bone around. You form bone around, it can't move as well. And it's a result of inflammation. Sometimes even just the bone spurs themselves hitting each other can be painful. But the biggest deal is pain, and really when we're thinking about treatment, that's what we're trying to solve. The main goal is really to treat pain. And so for our treatment, we often will start with anti-inflammatory medications or Tylenol. Anti-inflammatories are ibuprofen, Aleve, things of this nature. Tylenol is not an anti-inflammatory, but it helps with pain control. By bringing down the inflammation, you can bring down the pain, and that is the truth. The other thing that can be really helpful, I just mentioned in this video, is a brace. And the reason for that is one of the things that really causes pain in arthritis, especially of the ankle, is not necessarily stepping on the ankle and what we call axial loading the ankle. It's actually the movement of the ankle itself and the movement of those what used to be nice, smooth, glassy surfaces that are now these rough, pockmarked surfaces. And so by minimizing the movement of the ankle, you can really help alleviate the pain. And so a good lace-up stiff brace can really be a godsend. I have patients who are in these, they don't want to have surgery, they play golf, they get up and use every day, and it can be really, really helpful. They are bulky and cumbersome though. That's the downside of these, and they certainly don't work for everybody. Steroid injections can be helpful, just like arthritis of other joints as well. And again, it's like taking a whole bottle of that ibuprofen and shoving it right into the joint. It really cuts down the inflammation very, very well. The downside, of course, is that these are temporary. So once the effect of that steroid is gone, then things will creep back to where they were previously. And the steroid injections are very variable. Some people get great response from it. They can have 3 to 6 months of excellent pain relief. Some people get a few days, some people get a few weeks, and you don't always know until you try. Another slide next. PRP stem cells, they're very expensive, and they haven't been proven to work. And then as the NHS narrator talked about, when these non-operative treatments have failed, and when the arthritis is debilitating enough to really cause an impact in people's lives, that's when we start talking about surgery. And just a quick note on stem cells, because obviously the popular media loves talking about stem cells. It's a buzzword, so I'm going to talk about it. Stem cells are cells that really have the potential to differentiate into other cell types. And this has huge promise, because the idea is that these cells can heal. If these cells can turn into other cells, we can turn these cells into articular cartilage cells. We can turn these cells into heart cells, into brain cells, and we can solve a lot of the problems and heal a lot of these lesions. So it's theoretically possible to drive them to repair or replace damaged tissue. That's the promise. That's why they're so exciting. That's why so much money is being spent. That's why they give us $30 million to build that building behind us, because the promise is so huge. Today's reality is that it's very hard to get stem cells to act like we want them to. Trust me, I know. I spent a year of my life as a resident trying to get articular cartilage to do what I wanted to do, and they are stubborn as mute. Articular cartilage is particularly stubborn. It's particularly susceptible. It doesn't like to live. Articular cartilage itself is a highly structured substance that not only does the cells matter, but the extracellular matrix around it and how it's oriented really matters. And trying to develop that is very tough. And so the idea that you're going to inject these cells into this environment and they're going to automatically go and do and heal this one particular thing, it just doesn't work that way. Not yet. And so as a result, this is really expensive and unproven to this point, because we haven't figured out how to give those cells the right signal to get them to do what they do. And maybe 10 years from now, if I give this talk again, that statement will be very different, and I hope it is. But for right now, they're just not yet ready for prime time. And there are all kinds of small studies and anecdotal stories and YouTube videos and Facebook pages of people that will say stem cells were a miracle and they cured everything, but there are no good large studies actually demonstrating that. And so I cannot recommend them. So, when those other treatment options have failed, and you're thinking, gosh, this is really impeding my life, then the next step is surgery. We do have good surgical options for this problem. Two of the surgical options that I'm going to talk about briefly, because they are options. One is debridement, and debridement just means cleaning. And this is really reserved for patients who either have a very isolated area of arthritis, what we call osteochondral defects, or small lesions that we can somehow get to, or something like bone spurs, and it's actually the rubbing of the bone spurs more so than the joint arthritis that's causing pain. It's not good for widespread disease, and this is really for every joint. Just cleaning out the joint when you have widespread disease will temporarily give decent relief, just like the steroid injection, but eventually people are back to being the same. And so it's only really recommended for very specific instances. There is a procedure called cerebral osteotomy. I'll show you a demonstration of it on the next slide. And this is really for people who have deformity and pain in their ankles as a result of the deformity, but the joint itself is actually pretty good. And then we're going to spend a lot of time talking about fusion and replacement. So this is a patient of mine. He's a 45-year-old gentleman, super nice guy. I just saw him today, happened to come in. He works at a pizza parlor. He's on his field. He has a condition called multiple hereditary exostoses, where he forms these outcroppings of bone and cartilage. And as a result of that, he had a kind of a partial fusion of this syndesmosis joint, which is the space between the tibia and the fibula. As a result of that, his ankle was twisted as he was growing. So this has been what his ankles looked like. He's now in his mid-40s. This is what he's looked like since he was a teenager. And you can see that actually the joint space looks okay. It's just kind of at an angle. And so for these people, we don't necessarily have to do anything to the joint itself. What we're able to do is actually make cuts into the bone to realign that incidents. I've done 2 of these in 5 years of being a foot and ankle surgeon, so it's really quite rare that these come up, but it is a possibility. And so, but a rare one. And so to get on to really the main topic after my intro, we'll dive in a little bit to talk about fusion versus replacement. What are the good things, the bad things about each one? How does one make a choice? How do I make a choice? How do my patients make choices? Go through that. So, as we said earlier, ankle fusion is removing the ankle joint itself, removing all that cartilage, and turning the tibia and the talus into one solid bone. This is done by opening the ankle up, removing the cartilage, and then screws or plate and screws are in place to hold those bones together. Once that bond and that bone fuses together, it's only to hold it there temporarily, and so once the bone fuses, the hardware is superfluous, and it can actually come out if need be. Usually it does not. Sometimes we'll even put bone graft, either from a cadaver or from the patient themselves, into the space, especially if those surfaces are not completely together, and there's any kind of a void, you can put graft in the middle, and your body will actually grow across that scaffolding in order to fuse those 2 bones together. This is a very, very old technique. This is over 120 years old. It's a very good and proven track record, but it does come with some compromises. And we'll get into that in a second. Post-operatively, this is what it typically looks like. This can be done, believe it or not, as an outpatient. In some people on the same day. Oftentimes people will stay overnight in the hospital for a day or 2. Usually you're in a splint or a cast for anywhere from 6 to 12 weeks. And this is to help hold the ankle motionless, again, to allow those bony cells to fuse, to find the brothers and sisters across on the other side of the joint and fuse together. And you need to be off of it to allow that to happen as well, usually for anywhere from 6 weeks to 3 months. Fully fusing takes, on average, about 3 to 6 months, but I've seen it take up to 2 years sometimes. And then once fusion is achieved, you can really do anything, meaning that it is a solid bone. It's not going to break, it'll be there, and it'll be fused for life. So once things actually fuse, you really can't do anything safely. People are not generally doing these things anymore. So though you can run, very few people run. Though you can jump, very few people jump. The more likely activities are what you saw in that video: walking, hiking, swimming, biking. Those things are all quite doable, quite possible. Running, jumping, high-level athletic activities, especially sprinting, are really difficult and really unlikely after this. So what are the results of this? Well, actually, 75 to 85% of people will have good pain relief. Usually it's not complete pain relief, though it can be. For a lot of people, it'll be good pain relief to where they get to where their pain is on average, say, on a scale of 1 to 10, an 8, down to a 2 or 3. So people still have some pain, but it's much more manageable, and they're able to live their life. So about half of people will still have some pain. You do lose about 3/4 of your sagittal motion, so bringing your ankle up and down, that dorsiflexion, plantarflexion motion. You don't lose all of it, because some of it is taken up by the other joints that are around, the other hindfoot joints, what we call short arch joint and the subtalar joint. But we also know that when you fuse the ankle, these joints tend to move a little bit more than they would normally. You also lose a little bit of your inversion and eversion, meaning bringing your foot in and bringing your foot out. But you still can move, so it's not that your foot is completely stiff. As we saw in the video, people can walk, and you can still move a bit, but you do definitely lose motion. And so what are the potential complications that go with this? Probably the biggest one is actually number 2 right here, which is the adjacent joint arthritis. As I just stated, those other joints will move more when you fuse the ankle, but as a result of them moving more, it also means that they're seeing much more stress. And by seeing that those increased stresses, they are much more likely to degenerate themselves. So about 25 to 50% of people will actually see the joints around start to degenerate. And this can happen relatively short period of time or a relatively long period of time, and again, it's kind of highly variable. We say 5 to 15 years. I've seen it happen in 2, and I've seen it take 30, so it can be a little bit difficult to predict. One of the tough parts that we constantly fight as a surgeon is we do our darndest to get these to heal and to fuse together, but they don't always. And about 1 out of 6, or about 15% of people, will not fully fuse. About half of those people will be asymptomatic. They won't feel or have any pain. Those people we can kind of leave alone, but 7.5 to 10% or so, as a result of them not fusing, will continue to have pain, and that sometimes means you have to have a second operation to try and get it to fuse after that. People do walk with a decreased gait velocity, so they walk slower, and as a result of that loss of motion, both up and down and in and out, uneven surfaces and stairs and hills can be a little bit tougher, because your foot doesn't have quite the motion to accommodate those uneven surfaces that are there. One thing I did put up on here, infection with any surgery we do is risk. The infection rate is about 1 or 2%, and that usually happens early on.